So as Carol says, there's certainly been a revolution in NIPT, and there's no doubt that it's probably one of the most significant changes that we've had in prenatal diagnosis and certainly in obstetric practice. I'm just going to run through the history of NIPT, the technology, and just the future developments that we can anticipate going forward. Sorry, now figure this out. Okay, there we go. So with prenatal diagnosis, we have a large armamentarium, but it's kind of based on ultrasound, which is non-invasive. We have our first trimester screen where we can measure the thickness of the back of the neck and some biochemistry and gives a risk number for the patient. But certainly from a diagnostic point of view, it's more an invasive approach with a CVS or amniocentesis. Having said that, the needle approach is, although it is diagnostic and garners a lot of information, it's not without risk. And certainly the risk to the pregnancy loss is, for CVS, is about 1 to 2% and about 0.5% with amniocentesis. So there's certainly a desire to, improve the non-invasive approach for our patients to reduce this risk. Although, with the diagnostic test, as I say, the amount of information you can garner is improving with the development of microarray, and I think we're moving on to full gene sequencing. The non-invasive approach is where a lot of the research and a lot of the developments are focused upon at the moment. And this was finally realised in 1997 when Professor Low in Hong Kong, discovered the presence of fetal DNA in the maternal plasma. Now, previously, they were able to find fetal cells, but the problem with fetal cells is that they can persist in the circulation even after delivery, and the quantification is very, very difficult. So to actually do testing on these fetal cells was not going to be fruitful. However, with the finding of cell-free DNA, this was now possible. Cell-free DNA originates from the placenta, and it accounts for up to 10% of all the DNA in the circulating plasma in the mum. Free fetal DNA concentration increases as gestation progresses, and I'll get into this a little bit later. It is detectable from about 4 to 5 weeks, but realistically, from a testing point of view, from a quantification point of view, 9 to 10 weeks gestation is optimal. It's cleared from delivery cleared from circulation 30 minutes after delivery, and this is very important for future pregnancies to make sure you're testing the correct pregnancy. So now we have another, weapon in our armamentarium for when we're doing prenatal diagnosis. And very quickly after Professor Low's discovery, this technology was used for management of high-risk cases. And initially they used it to detect certain parts of the chromosome, and this would be for, say, the S or Y gene in the Y chromosome to detect whether it's a male fetus, and this is important for conditions such as CAH and also X-linked conditions. The other use was to determine the rhesus status of the fetus, and this would very much guide management in high-risk pregnancies. The term non-invasive prenatal diagnosis arose from the use of the technology for these conditions, and importantly, this test does not require an invasive confirmation. So that's something to keep in mind just for future slides. However, it wasn't until advancements in, gene sequencing and the possibility of doing massive parallel sequencing where you can have a targeted part of the sequence amplify it thousands and millions of times that allowed us to do more testing to actually figure out was there a chromosomal abnormality, and what we're looking for is an extra chromosome. Now, looking at the technology and how efficient it has to be, I think it's highlighted by the fact that if you do a CVS, you're looking for a kind of a 2 to 3 ratio. So you're looking for a 50% increase in the number of chromosomes, say for chromosome 21, which is Down syndrome. However, when you're looking at the plasma, because the fetal fraction of the DNA makes up such a small proportion of the maternal DNA, to be able to detect a slight increase in the number of chromosome 21s in the fetal DNA, you're going to amplify the sequences at a rate to be able to pick out this tiny, tiny difference. So unlike CVS, where you're looking for a decrease in chromosome 21 of 1.5 factor, it's only 1.05 when you're testing the plasma. With this new technology, and a lot of the labs would actually use the massive parallel sequencing and then compare it to a reference genome. The other technology is using SNPs, and I know the next speaker is going to go into this in a bit more detail. So this is single nucleotide polymorphisms. So I won't bore you too much about the technology, but from a clinical point of view, the difference is that instead of comparing it to a reference genome, you're actually comparing it to the maternal genotype. So you're actually using the buffy coat of the plasma and comparing the DNA of the fetus to that of the mum. So the limitations from a clinical point of view would be that you wouldn't be able to use a donor egg, twin pregnancy, or a mum who's had a recent transplant to actually do this test. But thankfully, there's a lot of different tests and different approaches on the market, so we can cater it to our patients. So now, within, I suppose, by 2008, a number of these commercial entities were looking for patents in this area. These tests were emerging onto the market. By 2011, it was on mainland China, then the US of A. It was here in mainland Europe by 2012. And we were essentially playing catch-up. These tests were now available to our patients. By 2011, there was over 100,000 tests that were being performed in 50 countries, and we were questioning, well, is this valid? Obviously, as they were developing the test, there was numerous of pilot studies being performed, but were we confidently able to offer this to our patients and say these were valid tests that were good enough to replace first trimester screening, etc. And the emergence and how quickly they mushroomed into society provoked us to do a number of cohort-based testing to validate it. And thankfully, the results did show that this is a very efficient test. When you're looking for trisomy 21, which is Down syndrome, the sensitivity was reported over 99% and specificity 99% in a number of studies with large cohorts. And just look at this in high-risk women. And this also rang true for the other trisomies. We're looking for 13 and 18, and also Turner's mosaicism. And you can see there that with the large number of studies, large number of cases, that the efficiency of the test was proven. We ourselves in Rotunda here were involved in a validation study with Natera. It was the prenatal study, and we were happy with the results that we garnered from our results also that led us to confidently offer this test to our patients. So now we have a test, non-invasive, with a simple blood test where we can give a report to a patient that her risk of Down syndrome is low risk, which is risk of less than 1 in 10,000. This is fantastic. On the flip side, if it's high risk, we can say to our patients there's a 99 out of 100% chance that the fetus is affected. So these are almost diagnostic tests. Why bother doing a needle test? However, over time, it did emerge that there can be discordance between the NIPT result and the ultimate outcome. And there's a myriad of different reasons for this, and this would include confined placental mosaicism, whether the mum herself has a chromosome abnormality, the presence of a solid tumour, copy number variance in the mum, and unknown twin demise. And for this reason, it's very much an important part of our counselling process that when you find a high-risk result, this is a screening test, it's not a diagnostic test, so it's very important that we do a confirmatory needle test. The other issue that emerged was that fetal fraction was very important, and this means the amount of DNA, the fetal DNA that's in the maternal blood. And most labs would need about 8% of fetal fraction to be able to perform the test efficiently. And the average is approximately about 10% per sample. But it is affected by maternal BMI. There's an inverse relationship, and it's also affected by gestational age. And that's why when we're doing NIPT, we also do a scan to confirm the dates to ensure that we're doing the test at the right gestational age. The other issue that has arisen is the no-call rate, and most labs will quote a rate of about 4 to 6%, and this means where despite the testing, they're not able to get a result. And we'd often offer our patients a second try. But there is more studies emerging to say that if there's a no-call rate, especially after the second try, that this itself might be reflective of aneuploidy, and these women need extra attention, whether you proceed with an invasive test or just do very detailed sonographic evaluation. So in the past, when this was initially, I suppose, formed part of our approach to prenatal diagnosis, the recommendations is that should only be offered to high-risk women. And this would encompass women over the age of 35, those with ultrasound findings of aneuploidy, a previous history, or previous testing that puts them into the high-risk category. And different institutions had different approaches. Some people offered first trimester screen first to deem whether they're high risk, and then proceeded with the NIPT as an option over invasive testing. We ourselves offer both tests to patients, but there's certainly a move more now towards NIPT as the first line screening test. One of our students from RCSI, part of the research summer school, did a very nice study looking at a year-long review of our management of cystic hygromas that attends the fetal assessment unit. Back in the day, this would be a 100% transfer rate to do a invasive test, whether it be CVS or amniocentesis later on. But we found even in the year after the introduction to NIPT that this rate dropped to about 68%. Now, there were certain circumstances where there may have been a history of recurrent miscarriage or fibroid uterus, but this kind of highlighted that we had kind of an extra modality to approach these patients, and certainly if they're not suitable for invasive testing or decline the invasive testing, that there is a reasonable option. However, that does not negate the fact that if you have a high-risk result, it should be confirmed with a needle test. So the next step then is to go beyond the high-risk population and to look at the low-risk population, and certainly there's a big drive, no doubt from a commercial point of view also, but there's a big drive to see if this is a suitable entity, and there's a lot of studies ongoing around the world to assess the validity of doing it in a low-risk population. A large study was published last year in the New England Journal, and it highlighted how well NIPT performs, that it supersedes the accuracy of first trimester screening, but also it remains accurate in the low-risk population. Having said that, within the low-risk population of the number of studies that are emerging, there is concern about the low positive predictor value and the cost-benefit to doing this in a low-risk population. The American College came out with recommendations at the end of last year, very sensible recommendations. And they certainly said that, at this stage, all screening modalities should still be discussed. It's important to confirm that the high-risk result with an invasive test, that no-call results should be, we should be taking heed of no-call results because of the increased risk of aneuploidy. And also they highlight again the limited data to emphasise the cost-effectiveness in the low-risk population. The other thing they say is that there's limited evidence yet in the role of NIPT with microdeletions and in twin pregnancy, and that more studies are needed. There's no doubt that NIPT is here to stay, but it is continuing to evolve. And the next steps are expanding the panel besides looking at the sex chromosome, trisomy 18, 13 and 21, to extend it into things like microdeletions. And some companies are even expanding it to include all the chromosomes, and the future no doubt will show massive, or do genomic sequencing. Wapner and his group looked at the extended panel with microdeletions, focusing particularly on the DiGeorge syndrome, and they were able to show very high sensitivity and specificity. However, they did a low number of actual cases, so used artificial mixtures to validate the test in the lab. So the authors themselves recognised that there was a need to validate this test from a microdeletion test in the normal pregnancy cohort. The Rotunda Hospital is part of the new SPART study by Natera, and this is a SNP-based technology, which the next speaker will talk to, but it's looking at microdeletion and aneuploidy registry, where we can actually do the test on our patients and follow the outcome. So our normal patients that would come for NIPT, that we would always also offer them DiGeorge testing. We record their outcomes and also record the neonatal blood spot to confirm whether the test was was correct and whether there was any false positives or false negatives. So this is an exciting study to be part of, and certainly this will help us counseling our patients in the future whether this is a test that we would recommend. As I say, this non-invasive test is going to continue to evolve. In the background, there's a number of research groups doing whole genome sequencing, and who knows the Pandora's box that's going to open. I suppose from our point of view, regarding the future, we have to wait to see what happens with the lowest population, whether that screening of the lowest population is a valid thing to proceed with. I think we have to keep abreast of all these rapid developments, and I suppose be aware of how to counsel our patients to give the correct information. There's a need for continued expertise in this area, and I think being part of ongoing research projects and developments is the best way that we can serve our patients. So I'm very happy that the Rotunda continues to be involved in these studies. I'd like to thank you for your attention, and I'm happy to take any questions. Thank you.